Welcome everyone to today's webinar. Let me just share with you for the next 30 to 45 minutes the learnings that I gathered in the management of sore throat. One of the definitions of sore throat is that sore throat refers to pain, itchiness, or irritation on the throat. A sore throat is pain anywhere in the oropharynx. Sore throat is a common physical symptom usually caused by acute pharyngitis or throat inflammation. There could be associated tonsillitis also. It is commonly associated with a cold and a cough. Now, sore throat, when it is pharyngitis, is diagnosed in 11 million patients in the United States emergency departments and ambulatory settings annually. It is truly very common. Most episodes of sore throats when it is infectious are viral, and you will hear me say this repeatedly throughout the course of this session. Bacterial infections only actually account for 15 to 30% of infectious sore throats in children and even lower in adults, only 5 to 20%. The anatomical basis of sore throat, as you all know, are the oral cavity and the oropharynx, like so. The oropharynx specifically has the soft palate, the uvula, the tonsillar pillar, the tonsils, the posterior wall of the oropharynx, and not labeled in the drawing, the posterior one-third of the tongue. So here again is another picture of the oral cavity and the oropharynx and its boundaries. So the clinical presentation of sore throat is usually that the patient comes to us, complains of, Doktora, masakit po lalamunan ko, or even outright saying, Doktora, may sore throat po ako. Sore throats can be painful and annoying. Fortunately, most sore throats are caused by a minor illness only, and they go away without medical treatment. Sore throat may also be described in different ways. Painful, raw, burning sensation at the back of the throat, painful throat, mostly when swallowing, scratchy, itchy throat causing coughing, dry throat, or even a bitter or sour taste in the mouth with associated halitosis. So how do we get sore throat? There are basically three general ways. Let us review that the mouth or oral cavity is considered to be the portal of entry of organisms which can actually cause mouth and throat infections. And as mentioned, these are usually viruses and bacteria. Secondly, the oral cavity itself, likewise, is already, to begin with, colonized by numerous different microorganisms which could also be important sources of infection given the right setting. They become opportunistic as we refer to them. So these are the specific bacteria colonizing specific areas in the oral cavity. And factors that can alter bacterial flora are the use of tobacco, pregnancy, dehydration, poor immune response, and antibiotic administration. These factors can make pathogens opportunistic. And lastly, we get sore throat when we have an upper respiratory tract condition in the nose. It may be allergy, it may be an infection, but then post-nasal drip can develop, and this may contain bacteria which infect the tonsils and the pharynx. So the common causes of sore throat are viral infections, bacterial infections, even fungal infections. You also have mucositis, aphthostomatitis, allergy. Nowadays, acid reflux is becoming a common cause of sore throat, and admittedly, in some cases, the exact cause of sore throat is still unknown. So, in literature and among colleagues, in conferences, and scientific discussions, and even in the lay population, sore throat is usually equated to tonsillopharyngitis. Tonsillopharyngitis is usually viral, most often caused by the common cold viruses. In about 10 to 30% of patients, only is the cause bacterial. And still, through the decades, group A beta-hemolytic streptococcus is the most common bacteria to cause sore throat. And we call it gas pharyngitis. The objectives, therefore, of this webinar is number 1, to present the recommendations for the diagnosis of gas pharyngitis, including differentiating between viral and bacterial tonsillopharyngitis, and to discuss the recommendations for the treatment of gas pharyngitis. After all, gas pharyngitis account for the majority of the sore throats we encounter in clinical practice. A third objective is to enumerate other diseases that can cause sore throat. And lastly is to review the role of topical solutions for the management of sore throat. This is my disclosure for this webinar. So for objectives number 1 and number 2, let's go to the recommendations for the diagnosis and treatment of gas pharyngitis. The major reference for this sharing is the IDSA guidelines, where they publish the clinical practice guideline for the diagnosis and management of Group A streptococcal pharyngitis by the Infectious Diseases Society of America. So gas pharyngitis is the most common bacterial cause of acute pharyngitis. As mentioned, it occurs in 5 to 15% of all infectious sore throats for adults and 20 to 30% more common in children. Why is it important to accurately diagnose gas pharyngitis? Because it's important to give the proper treatment, which is an appropriate antibiotic. It's important to treat gas pharyngitis because of prevention of rheumatic fever, prevention of suppurative complications, to improve the clinical signs and symptoms the patient is encountering, to have rapid decrease in contagiousness, to have a reduction in the transmission of the bacteria, to allow rapid resumption of usual activities, and for minimization of potential adverse effects of inappropriate antimicrobial therapy. So the bacterial causes of sore throat treated with an antibiotic are very few aside from gas. This may be the occasional Corynebacterium diphtheria and Neisseria gonorrhea. Even the other bacteria that cause sore throat don't necessarily need antibiotic therapy. Inappropriate antibiotic therapy exposes patients to unnecessary hazards and expenses and contributes to development of antimicrobial resistance locally and worldwide. So it is always our responsibility to make sure that antibiotics are indicated in the treatment of sore throat. Ergo, we always have to make sure that the sore throat is being caused by bacterial organisms. So the common problem now or challenge to us as responsible clinicians is to always be able to differentiate between viral or bacterial tonsillopharyngitis. Viral pharyngitis, as you all may well know, are characterized also by conjunctivitis, coryza, cough, diarrhea, hoarseness, discrete ulcerative stomatitis, pwede pong may mga singaw, and viral exanthema may also be present. In gas pharyngitis, the clinical presentation usually includes a sudden onset of sore throat, epidemiologic data of age 5 to 15 years, that's where it's most common. Of course, there's fever, headache, nausea, vomiting, and abdominal pain. And on physical examination, a patient may have tonsillopharyngeal inflammation, no big deal, that's also present in viral. But this is more unique for gasopharyngitis. This entity, patchy tonsillopharyngeal exudates. Palatal petechiae may be present. Anterior cervical adenitis. In the Americas, winter and early spring presentation, history of exposure to gasopharyngitis, and scalatiniform rash. So various scoring systems have been developed to help the clinician differentiate between viral and bacterial sore throat. We all probably recall the Centor criteria in the diagnosis for strep throat, and the criteria items there that favor bacterial infection would be the absence of cough. So pag medyo inuubo-ubo, baka viral. Pag walang cough, nako, baka mas bacterial. Tender cervical lymphadenopathy, fever of greater than 38.1 degrees centigrade, and on physical examination, tonsillar exudates. Another criteria, which is called the modified Centor, is the MAC-ISA criteria, which just actually included epidemiologic data, which is the age of the patient. If it's 15 to 44 years of age, there is 0 points. If it's 3 to 14 years, that's when you get the 1 point to favor a bacterial infection. And if it's less than 3 years old, it might not be bacterial infection because gasopharyngitis is not common in the pediatric population younger than 3 years old. Another example of an algorithm that clinicians use to help us differentiate between viral and bacteria. So there is a broad overlap actually between the signs and symptoms of streptococcal and viral pharyngitis. All these patients may have fever. All these patients may have, of course, swelling and redness in the throat. And the systems attempt to predict the probability that a particular illness is gasopharyngitis. And these scoring systems have been found to be helpful in identifying patients who are at such low risk of streptococcal infection that performance of a throat culture or a rapid antigen detection test is usually unnecessary. However, in children, these scoring systems on the average detect only about 35 to 50% of the bacteriologic confirmation, of the bacteriologic etiology. And bacteriologic confirmation is recommended by the IDSA. Bear in mind that other bacteria, as I mentioned earlier, may cause sore throat. The more common ones, but a far second group in terms of occurrence to gas is Corynebacterium and Neisseria gonorrhea. You also have these other several bacteria that can cause sore throat. So gasopharyngitis is actually the only practically common occurring form of acute pharyngitis for which antibiotic therapy is definitely indicated. Therefore, for a patient with acute pharyngitis, the clinical decision that usually needs to be made is whether or not the pharyngitis is attributable to gas. So according to IDSA, to definitely establish the diagnosis of group A beta hemolytic streptococci as the cause of the sore throat, they recommend a rapid antigen detection test and or culture. The rapid antigen detection test, when it's negative, should be backed up by a throat culture, especially for children or the population 5 to 15 years of age. A positive RADT does not necessitate a backup culture. What does this mean? For a negative RADT, the negative RADT is not very reliable because the sensitivity of the RADT is only about 70%. It can go as low as 70% to as high as 90%. Ibig pong sabihin, Pag sinabi ng RADP na hindi group A beta hemolytic streptococci ang cause ng sore throat, may chance pa na 30% na mali ang RADT. So dapat pa tayong magpa-throat culture in chosen populations. But because of the high sensitivity of an RADT, sa specificity of an RADT, a positive RADT does not necessitate a backup culture anymore. Just in other words, if the RADT is positive for group A beta hemolytic streptococci infection, you can believe that it's positive indeed. A routine use of backup throat cultures for negative RADT is not necessary for adults. Why? Group A beta hemolytic streptococcal infection is relatively uncommon in adults, and more importantly, the feared complication of acute rheumatic fever is really not common in adults. And anti-streptococcal antibody titers are not recommended in the diagnosis of pharyngitis. Sometimes we have patients coming to the clinic, may dala ng ASO titer result. What does it indicate? Para po for me, ASO is like PPD. It's indicative of past infections, but it's not indicative of a present active infection, and therefore you don't need ASO titers to decide in the management of acutely ill patient. So there, laboratory diagnosis, you can do throat culture and you can do RADT. I am speaking academically. Clinically, we do empiric treatment in our setting. We do not do throat culture and RADT before we give antibiotic therapy if clinical parameters point to a bacterial source of our pharyngitis and or tonsillitis. But just to touch on it, how do you do throat culture? You swab. The specific areas to swab in the throat would have to be the surface of the tonsils and the posterior pharyngeal wall. In an uncooperative child, you cannot settle with swabbing just the mouth or the tongue, or the pharyngeal walls or the tonsillar pillars. The specimen has to be obtained from the surface of the tonsils or the posterior pharyngeal wall. Secondly, the culture has to be put immediately in the sheet blood agar plate, and this has to be incubated for 18 to 24 hours. After 24 hours, can it only be read? At pwede pa pong may tumubo for as long as 48 hours. So if you did that culture and you gave your antibiotic therapy already, please be honest enough to check the culture result after 48 hours. There might be other growers. The rapid antigen detection test, as the name implies, takes care of the disadvantage of the throat culture. Sa throat culture, kailangan pa po maghintay at least 24 hours. What if the patient is so toxic already? We do empiric treatment, and in developed countries, especially where managed care is very authoritative, RADT has to be done. Okay, my best friend from the United States, Dr. Agnes Chalwangco Dawis, UPCM class 92, tells me she cannot. It's not that she does not, because she cannot prescribe antibiotics for the pediatric population without doing an RADT. Who should undergo testing for gasopharyngitis? In our setting, majority do not undergo testing. We give, as I said, empiric antibiotic therapy based on our clinical assessment. Testing for gasopharyngitis usually is not recommended for children or adults with acute pharyngitis with clinical and epidemiologic features that strongly suggest a viral etiology. Diagnostic studies are not indicated for children less than 3 years old. Acute rheumatic fever is rare. Gasopharyngitis is rare in this age group. Follow-up post-treatment throat cultures or RADT are not recommended routinely. You don't need to do this as a follow-up. And diagnostic testing or empiric treatment of asymptomatic household contacts of patients with acute strep pharyngitis is not routinely recommended. What are the treatment recommendations, therefore, for patients with gasopharyngitis? For the past 70 years or so, penicillin remains to be the drug of initial choice for group A beta hemolytic sore throat. Amoxicillin can also be used. Both are recommended for 10 days. Penicillin is still the #1 choice because of its relatively narrow spectrum of activity, efficacy, safety, and relatively low cost. If with penicillin allergy, first-generation cephalosporins for 10 days, clindamycin or clarithromycin for 10 days, and azithromycin for 5 days are also options. So the goals of therapy, why do we treat? Honestly speaking, if you search the literature, even gasopharyngitis caused by bacteria yan, it can resolve in 4 to 5 days, even without antibiotic. But the goal of therapy is to reduce the duration and severity of clinical signs and symptoms, including suppurative complications. It's most beneficial when you give the antibiotic within the first 2 days of the illness, and you can avoid the suppurative complications, peritonsillar abscess, cervical lymphadenitis, even mastoiditis. Now, for me, the most important goal of therapy for gasopharyngitis is this, the #2 in our list, reducing the incidence of non-suppurative complications. Primarily, especially in the community, in our country, in our setting, acute rheumatic fever. Antibiotic therapy is effective to eliminate gas from the oropharynx up to 9 days following the onset. Kahit medyo nahuli tayo pag-diagnose o ang pasyente galing ba sa kabilang baryo, hindi natin siya nakita agad. Huwag tayo malungkot. Sabi sa literature, up to 9 days, tatalab ang penicillin para hindi siya magkaroon ng acute rheumatic fever. The role of antibiotic therapy for glomerulonephritis and PANDAS, these are other, not so famous, non-suppurative complications of gasopharyngitis. The role of antibiotics, not clear for these complications. The third goal is to reduce the transmission of close contacts by reducing infectivity. Did you know that after 24 hours of treatment with penicillin, there's already an 80% eradication rate of the bacteria from the oropharynx? What does this mean? Hindi na po nakakahawa ang pasyente after 24 hours of gamot pag ito po ay naibigay nyo na. Appropriate antibiotic at an appropriate dose for an appropriate duration likely to eradicate the organism from the pharynx. That's why it's at 10 days. And I said this already, narrow spectrum of activity, infrequency of adverse reactions, modest cost, penicillin or amoxicillin is the recommended drug of choice. In general, I will emphasize antimicrobial therapy is of no proven benefit for treatment of pharyngitis due to bacteria other than strep, with the exception of Corynebacterium and Neisseria. So if you give a necessary antibiotic, I will emphasize you expose the patients to potential hazards and to the expense, and you contribute to the emergence of bacterial resistance. Antibiotic resistance is not a significant issue in the treatment of gas due to gas probably altered PBPs and the inefficient gene transfer mechanisms of these organisms. So should adjunctive therapy be given to patients with gasopharyngitis? Doktora, nagmumug na po ako ng mainit na tubig na may asin. Ay, okay po. Wala naman pong masama dyan. Pero hindi ho yan inaalis ang group A beta hemolytic streptococci. Adjunctive therapy may be useful in the management, if warranted, use of an analgesic such as acetaminophen or NSAID for the control of pain and fever should be considered. Aspirin should be avoided in children. Adjunctive therapy with the corticosteroid is not recommended for gasopharyngitis. How about topical agents? Topical agents, your favorite gargle or antiseptic oral solution may, yes, give temporary symptomatic relief. Is the patient with frequent recurrent episodes of apparent gas pharyngitis likely to be a chronic pharyngeal carrier of gas? Consider that patients may be experiencing greater than one episode of gas pharyngitis at close intervals or be a chronic pharyngeal gas carrier who are experiencing repeated viral infections. Gas carriers, there are no diagnostic tests and no treatment necessary. Tonsillectomy is not recommended solely to reduce the frequency of gas pharyngitis. And I cannot leave the topic, of course, without mentioning the indications for tonsillectomy. According to our very own PSO-HNS CPG 2006, the latest update coming out soon for 2016, tonsillar hyperplasia accompanied by any of the following. Number 1, upper airway obstruction, and number 2, dysphagia are indications for tonsillectomy. Recurrent tonsillitis, as from the sign, the Scottish guidelines, is also an indication. What is recurrent? Gaano kadalas ang madalas? 3 episodes in 1 year? 7 episodes in 1 year, 5 episodes per year for 2 consecutive years, and 3 episodes per year for 1 year. Doktora, sinabihan ho ako magpa-tonsillectomy na daw ho ako kasi madalas ho ako magka-sore throat. I say, siguraduhin muna natin, ang sore throat mo ba ay dahil sa virus or dahil sa bacteria? Dahil yung madalas na nagkaka-sore throat na kailangan tanggalin ang tonsils, dapat bawat episode ng sore throat ay bacteria. Hindi counted ang viral episode. Peritonsillar abscess or other complications can also be, of course, an indication. Again, I cannot leave the topic without touching on prevention. You have to avoid, of course, those who are obviously sick while they are sick. Carriers can also potentially be infective, but they do not require antimicrobial therapy. Foodborne illnesses, outbreaks have been associated with foodborne streptococci. So food handling, food preparation must be always according to standards. Prophylaxis, continuous antimicrobial prophylaxis is only appropriate for prevention of recurrent rheumatic fever for patients who have experienced a previous episode of rheumatic fever. And at present, there is no vaccine against gas available for clinical use, unlike in otitis media. Objective number 3, just a quick enumeration of other diseases that can cause sore throat. Singaw, aphthostomatitis, after are considered the most common inflammatory conditions of the oral mucosa, may also be commonly found in the oropharynx. The etiology is still unclear, and virus of the herpes group have been identified as possible etiology. I always say, isa lang ang siguradong cause ng singaw, trauma. Pag nakagat mo ang labi mo ngayon, bukas may singaw ka. Pag yung dentist mo, kinabitan ka ng braces today, bukas makalawa, pwedeng may singaw ka, nasugatan ka eh. All the rest are just theories. Hormonal imbalance, gastrointestinal disease, emotional distress, stress. Doktora, pwede po bang dahil sa stress ito? Ay nako, napakadali kong sagutin yan. Ang lahat ng sakit, pwedeng ang sagot dahil sa stress. Aphthostomatitis, of course, can coincide with viral infections, herpes simplex type 1, and there may also be superimposed bacterial infections, also Coxsackie viruses, and even, sadly, increasing in our country, HIV infections. I just want to share that the occurrence of a cytomegalovirus infection has been identified as a potential cofactor for the progression of human immune deficiency virus disease and tends to affect patients with an advanced immune deficiency. Another one, the presence of oral hairy leukoplakia is already considered as pathognomonic for an HIV infection. and this is believed to be caused by the Epstein-Barr virus. Not so rare, fungal infections of the mouth and throat, usually by Candida albicans, characterized by creamy white lesions, common in infants, those with unclean dentures, those who are using inhaled corticosteroids, and compromised immune systems. Also, those who have undergone radiotherapy, chemotherapy, those with uncontrolled diabetes mellitus, those who have been using antibiotics for a long time, as I said, those with corticosteroid inhalations and HIV infection. And here is a picture of candidiasis in HIV infection. Fungal infections, fungal infection. Other bacterial infections that can cause sore throat, TB, the great mimic, and syphilis. Mucositis for those of us who deal with head and neck cancer. Oral and oropharyngeal mucositis is known as the inflammation and ulceration of the mucosa, and it's a side effect of cancer, chemotherapy, and radiotherapy. And this can be a potential source of life-threatening systemic infection and has to be dealt with. Allergy can cause sore throat, and as you all have heard, acid reflux. Last objective, to review the role of topical solutions for the management of sore throat. Treatment of sore throat should be targeted to the specific etiology or disease causing the sore throat. However, for most sore throats, topical solutions may be effective for relief of symptoms. Thus, in the general management of sore throats, topical solutions may be used. A topical oral and oropharyngeal solution may be an antimicrobial, anti-inflammatory, analgesic. Many different solutions are available. Topical solutions are adjunct and not substitutes for regular brushing and flossing, and the encouragement of gargling is important for the control of opportunistic and community-acquired infections. Gargling is preferred by physicians over lozenges because of its mechanical effect of cleansing the oral cavity and the throat of microorganisms. Also, lozenges also pose the risk of choking in younger patients. Gargling with simple salt and water has a cleansing effect. With a commercial mouthwash, may add a freshening effect, but when you gargle with an antiseptic, you may aid in eliminating the bacteria and cure the disease fast. I just want to share this. Look at this. Management of viral throat infection coming from our sponsor. They gave this to the organizers. Tingnan nyo to. Antibiotics, 101 respondents. Management of viral throat infection, 15 pa rin. Favorite, oral antiseptic solutions. And among the common brand of anti-sore throat agents, the favorite common brand of patients, Strepsils. Pangalawa, Bactidol. Hexetidine or Bactidol is a broad-spectrum antiseptic. It is commonly used as a local anesthetic, astringent, and deodorant. Suppressive action on inflamed oral mucosa and deodorant effects in the oral cavity were first extensively reported way back in 1958. It's a hexahydropyrimidine, and it arrests thiamine metabolism of microorganisms, inhibiting their growth. They are cytotoxic to envelope viruses, and therefore the major mode of action is on the lipid-containing envelope of the viruses. It has been labeled for the symptomatic treatment of streptococcal pharyngitis, tonsillitis, pharyngitis, laryngitis, gingivitis, ulcerative stomatitis, oral thrush, and Vincent's angina. Post-operative hygiene following tonsillectomy and throat or oral surgery. For my segment before the summary, managing sore throat, get lots of sleep, rest, drink lots of water, treat yourself with comforting foods and beverages. If you can, humidify the air and avoid irritants. In summary, sore throat is discomfort in the oropharynx, usually due to inflammation. The most common disease presenting a sore throat is infectious tonsillopharyngitis. Viruses are the most common cause, and it is important, it's our responsibility to distinguish between viral and bacterial etiologies and not prescribe antibiotics indiscriminately. The recommendations for the diagnosis and treatment of gasopharyngitis are guidelines for effective management. The treatment of sore throat should be targeted for its specific etiology. In general, adjunctive treatments such as topical antiseptic solutions can be used for most sore throats. Thank you everyone for listening to the webinar.
Thank you very much for that insightful lecture, Dr. Tej Cruz. We would like also to thank today's sponsor, Johnson's & Johnson's. Before we proceed to our question and answer portion, let's have one of our panelists give his reactions. May we introduce Dr. Emmanuel Ibay, a specialist in otorhinolaryngology and head and neck surgery. He graduated from the University of the Philippines College of Medicine in 1991 and had his residency in otorhinolaryngology at the University of the Philippines Philippine General Hospital in 1995. In 1996, he became a clinical and research fellow at the University of Manchester Royal Infirmary in Manchester City, United Kingdom. The following year, he took the position of a visiting fellow at the Great Ormond Clinic Hospital for Children in London. Dr. Ibay is currently an active consultant at St. Luke's Global City and Makati Medical Center. Dr. Ibay.
Thank you very much for the kind introduction. Thank you, Dr. Tej. Thank you. I'd just like to add also that in the lecture of Dr. Tej on the importance of Group A beta hemolytic strep or Group A streptococcus infections. The reason being that infections of this cause complications of glomerulonephritis and rheumatic heart up to about the age range of about 29 years of age. So if your patient does seem to have frequent infections from gas, between a tonsillectomy and open heart surgery and a renal transplant, I think the tonsillectomy is a much easier surgery. And also, it's important to take the history of the patients when you see them, because there are also I'm seeing a lot of oral thrushes due to anti-asthma inhalant medication. So where the patient does not properly do oral hygiene after use of their inhalant steroids. And also good history on the patient's lifestyle, especially with all these young millennials in call centers going to their favorite Starbucks, suffering from a lot of acid reflux diseases, or even teas alone, which they get surprised that tea has caffeine. Some of them even are not aware of that. Also, intake of a lot of menthol, mint candies is a very strong reflux inducer in the sense that because it causes relaxation of your esophageal sphincters, and even chocolates. So do check on the history of that. And yeah, so I was just surprised also that Dr. said that don't use the ASO, anti-streptolysin O, as a factor in treatment positions.
I said that you don't need the ASO determination to treat an acute episode of sore throat. Yes, you can use it in management decisions for patients with repeated attacks of acute pharyngitis, so that you can see if the previous attacks were bacterial and help you decide if you would want to advise tonsillectomy. But it was under the slide where it was under the frame where diagnosis for an acute attack. So bottom line, you don't need to ask for an ASO just to give an antibiotic treatment for an acute attack.
How about also staphylococcus infections?
Okay. So staphylococci.
I noticed it was not.
It was not in the
list.
It was not in the list of the bacterial pathogens. Yes, it's not in the list of bacterial pathogens. the already very far second group in terms of epidemiology, in terms of prevalence, is the Neisseria group and the Corynebacterium group. And those, the others that were mentioned, were already even more rare, and staph was not there. So Staphylococcus infection of the throat is not a significant entity clinically.
So the Neisseria means also there is that
the
a
history is very important. Yes,
history.
Dr. Ibay. The history is very important. Always we tell our students, do not forget to take a complete and accurate history, because 80 to 90% of the time, just by obtaining a good history, you will already have a correct diagnosis clinically. And this is also very true for sore throat.
I myself have been able to pick up a number of cases where they have oral candidiasis. And
yes.
It turns out on history,
yes.
the patient has active sexual life, and of course, when we tested for HIV,
we
have
test,
turned out
yes.
positive.
Sometimes it's not very actively considered HIV. Some of us still are not very conscious about HIV already being on the rise in our settings. So we just want to also remind everyone, if you have frequent sore throat characterized
Have
by,
that in the back of your mind.
yes, always have that in the back of your mind. Of course, you always combine history and physical examination, and have the patient tested also for HIV, especially if you have frequent infections and not typically responding to your antibiotics. Because if you know, as you know, if it's really a pharyngitis, in 1 to 2 hours with penicillin, or 1 to 2 days with penicillin or amoxicillin, you will already have significant improvement.
Sometimes it's quite, they get alarmed when you say that they'll be tested for HIV. So I normally ask them that we will do an immunopanel test on them, not exactly saying outright the HIV test, because some of them do become a bit guarded when you say that. So I just say we do a CD4, CD8 immunopanel test. And then when that result does come out as relatively positive, we tell them
the results.
The results.
Yes.
Go ahead.
I just also want to add, I forgot in my haste because of our time constraints. There's this entity called infectious mononucleosis. It's a viral infection of the oropharynx that really mimics a bacterial infection. Even the physical examination findings have patchy white exudates and enlarged lymph nodes. You have to have a good history and a high index of suspicion. Infectious mononucleosis is viral. It's caused by the Epstein-Barr virus, and antibiotics are not only not indicated, but they may result, the use of the usual antibiotic for gas may result in a life-threatening rash in a patient with infectious mononucleosis. So please have a high index of suspicion, and if you're really not sure, then maybe you can start the patient on clindamycin. At least it's not notorious for causing the rash in infectious mononucleosis patients. And you can do a monospot test and later on other serologic tests for the specific antibodies for infectious mononucleosis.
EBV, IgG, IgM.
Yes.
Okay, thank you very much, experts. We have quite a number of questions, so I'll read through them. I request as short possible so we can answer as many questions as we can. So there's a question from Dr. Ami Beloy. How do you manage strep carrier child when the siblings keep getting ill from strep?
How do you manage
manage strep carrier child when the siblings keep getting ill?
Okay, prophylactic antibiotics are not recommended for the carriers. The ill children have to be tested. Are they also carriers? And are they getting bouts of active group A beta hemolytic streptococci? Or are they just getting bouts of viral sore throats? And then you manage accordingly.
Thank you. What is, from Dr. Dualan, what is the availability of the rapid antigen test in the Philippines?
Before I came here, I called my class. I was calling Dr. Ana Ong Lim. I was calling Dr. Carmen Rivera. They were not answering. I called Dr. Suratos. Dr. Suratos said it's not widely available.
From Dr. Gigi Goron Reynoso, what makes an adult with gas pharyngitis at risk for complications of strep throat? Risk factors. Anyone?
So, yes, an adult with other comorbidities, specifically targeting the immune system, leading to a poor immune response, are susceptible to the complications of gas pharyngitis.
It's increased ASO, and usually the age range of till about 29 years puts them at high risk.
Epidemiologically speaking, that's the pattern.
From Dr. Rowena Genuino, is throat gram stain advisable to diagnose gas?
It's not in the recommendations. It's RABP and culture. Hospitals, major hospitals have RABP, but in the States, even pediatricians in their own private practice, in their clinics, have RABP.
Is greenish yellowish phlegm a good marker?
Not at all. The color of the phlegm has nothing to do with differentiating between viral and bacterial infection. It may just be the result of oxidation.
From Dr. Martha O'Malley, how do you manage a patient who consults but already self-medicated with antibiotics?
If the diagnosis is viral, I tell them to stop the antibiotic.
Well, depends also if there are other underlying, like if there is Quincy's abscesses, then of course it would have to be through intravenous already, or if there's deep neck cellulitis, then it would have to be more aggressive in management.
From Dr. Melody Lazo, good afternoon, Doc. Maaari po bang pakiulit niyo ang guidelines na nabanggit niyo patungkol sa recurrence of tonsillopharyngitis prior to recommendation for tonsillectomy?
Opo, usually po ina-adapt natin, ma'am, yung SIGN guidelines, SIGN. It's a Scottish guidelines. If you want to read more about it, ang ganda po ng discussion, easily downloadable. You just log into SIGN, SIGN. Roughly, episodes of bacterial tonsillitis occurring 7 times a year for 1 year, 5 times per year for 2 consecutive years, and 3 times per year for 3 consecutive years are already an indication for tonsillectomy.
From Vanica Mariel, I think you answered it already. Kindly repeat the definition of recurrent tonsillitis, so you did already. There's a request to view the algorithm again because the slides were too small. So are those the...
Actually, a tip lang po, these algorithms are easily downloadable for free.
Okay.
You may get clearer copies from the internet. When I took the picture, of course, the resolution suffered, but they are easily... Will I click to show?
It's okay. We can just share it with the links with the participants later on.
Yes, we will just share the links later on.
Yes.
But if there are points that you want to clarify, they are easily also discussed there.
It takes some time for the images to download, so some of them had them pixelated. So we'll just, during the evaluation, we'll send them the link.
That's a good comment.
Last question from Jalila Lau. What is the role of coamoxiclav in the treatment of gas pharyngitis?
Well, it treats the group A the beta-lactamases, of course, and group A beta hemolytic pathogen. That would help prevent complications also of gas, which is the glomerulonephritis and rheumatic hearts in infected patients.
Okay. And when will the ASO titer be considered significant in the scenario of SARS-CoV? When is an ASO titer significant?
Usually that would be, if it's a relative indication, if it's elevated for a tonsillectomy already.
If it's increased, it is indicative of past true beta hemolytic streptococcal infections, and therefore the patient may warrant tonsillectomy.
Okay, thank you very much. After the session, an email containing a survey link will be sent to you. After answering the surveys, your certificates will be sent to you. Any last words from our speakers?
So I just want to say, take-home message, 90% of all sore throats are viral. Please do not prescribe antibiotics left and right. Supportive treatment is usually adequate. We have very good oral antiseptic and oropharyngeal antiseptic solutions, as was shown in the slide. The more popular one is hexetidine or Bactidol, and we have relied on it for many years, and also other antiseptic solutions and homegrown remedies like chicken soup, lots of rest, lots of water. Thank you.
Thank you very much. Hope to see you again in our upcoming webinars in March. For the first week of March, we will have a webinar on retinoblastoma with speaker Dr. Gary Mercado, March 2, 12 noon Manila time. Please invite your colleagues to join this continuing monthly CME webinar series. All webinars, schedules, and resources will be posted at upm.edu.ph UPMed webinars. We also thank today's sponsor, Johnson & Johnson. On behalf of UPCM Class 1991 and the UP Medical Alumni Society, we also thank our collaborator units, the UP Manila Information Management Services, National Telehealth Center, UP College of Medicine, Postgraduate Institute of Medicine and Medical Informatics Unit, DOST, ASTI, and Ms. Charisse Orjalo, our host. This is Dr. Marcelo, together with Dr. Teresa Cruz and Dr. Emmanuel Ibay in the UP Med webinar team closing this session. We hope you have learned a lot from today's webinar. Join us again on March 2. Have a great week ahead.